145 to 245. Okay, there are many slides, and I'll just skip few slides and show you the very important ones. Okay, and see, you people have now, you are in 5th semester. Okay, so the thing is that when you are posted in clinical posting, so at that time you will be encountering patients, and then you should know, you will see various patients, and you will be seeing the various type of various type of cases where we have been doing pre-operative workup for the patients, and the post-operative patients also. So for pre-operative workup, it's actually a very vague topic, but a few things you have to be very particular about working with the patient. So so the patient assessment, risk assessment, consent, arranging the theater list. So there are gross topics. So now when you are assessing the patient, we usually, whenever we see the patient, there is something called as ECOG performance status. Okay, so that is Eastern Cooperative Oncology Group, which is used in most of the cases when we operate. So whenever we write some on examination finding, we'll see the ECOG, the performance status of the patient. So it is classified into 0, 1, 2, 3, 4, 5. Okay, so most of the patients have 0, 1, 2. Okay, so many patients will be in that grade. Okay, and then very few patients will be on 3, 4, 5. So this is ECOG. Remember, ECOG performance status has to be mentioned. So patient assessment, whenever you do patient assessment, the aims is look actively at risk, proper management of the risk, enabling safe surgery. So the aims is that whenever we talk about the patient assessment, we talk about the risk, whatever risk the patient is having. Maybe the patient is having some comorbidities like diabetes, hypertension, or some treatment he or she is undertaking. Okay, so you have to manage the risk, and so that the risk is reduced, and you have to have a very safe surgery. So you see for the risk, manage those risk whatever possible, and then only put the patient under any surgical treatment. So usually it is done by surgical team, nursing team, anesthetic team. So surgical team means the surgeon, his assistants, and the residents, and the medical officers or the house surgeons, and the nursing team, and the anesthetic team. So everybody has to see the patient and find out about the risk of the patient. So standard history taking have to be done. Okay, so whenever you do physical examination, so you have to see various things, and then you have to do a investigation. So you can see the nice guidelines for investigations. Okay, so jot down all these important points, and then you can see in your book or in the net regarding tool used in our part of the world called Malampati scale. Okay, it's used by anesthesiologists most of the time, and they will ask the patient to open the oral cavity and see the various classes of the oral cavity. You can see the difference. Okay, where in the last one you can see only the hard palate is visible. Okay, so in these sort of cases, what will happen is that the patient intubation, when you are doing an intubation, so endotracheal intubation, for giving general anesthesia, it will be difficult in the class 4. So you will anticipate the difficult intubation and keep all the tools ready for doing difficult intubations. Like you will put the endotracheal tube, the guide. Okay, the metallic guide will be there, and then you may have to have a bronchoscope to guide the guide wire and push the endotracheal tube. So similarly, and you will have a very good assistant with you, or maybe maybe you will ask for your senior who is more expert to be standby and plan for an intubation. Okay, so this type of assessment will give you more information and you will anticipate the difficulty. So risk assessment and consent. So whenever you take risk assessment, you classify. So the ASA classification, okay, this is mainly the risk assessment. I'll talk about ASA again. And then, so explain on the advantages, side effects, and the prognosis, taking comprehensive valid consent. So consent, it should be an informed consent by a competent and informed person. So the patient and his relatives. Usually what you do is you ask the patient, we tell the patient about the various what surgery you are going to do, and then what are the different complications of the surgery. And then what you'll do is you'll ask the patient and the relative to sign the consent form. Okay. So many places nowadays people have started doing the video, video recording also of the informed consent. So you have to talk about what is the surgery, what procedure the patient will undergo, and then what are the possible complications, and then how we are going to tackle those complications, and how many days the patient has to stay in the hospital. So everything has to be explained in the case of informed consent. So when you talk about ASA, so it is classified into 1, 2, 3, 4, 5, and E. So ASA is American Society of Anesthesiologists. Okay. So in that, the ASA 1 and 2 is usually the normal where the patient don't have to be evaluated in detail. Okay. But in ASA 3, 4 patients, then that is a very difficult cases where you expect many complications due to anesthesia and due to surgery. So mainly because the patient is a little bit moribund in these sort of cases. So you have to evaluate the patient in you have to do all the tests. So which will lead to and then you have to explain the patient regarding the informed consent. So in this case, in every case, the anesthesiologist will also take the consent, and you have to take the consent as a surgeon, and then or an anesthesiologist, and then the sisters in the ward, they will also take the consent regarding various issues. And arranging the theater list. So you should first fix the date, time, place of operation, and then the various aspects, and then the operation list has to be made, and then you have to give priorities to the children, diabetic patients, cancer patients, and life-threatening patients, and the appropriate equipment and the instruments has to be made available. Okay. So so for that, if you need some, so you are going to undertake a major surgery, and then some special type of equipments you need, or some special type of retractors you need, so that you have to tell prior. You have to send the list to the sisters in the operation theater, and they will arrange for you beforehand. So in that in those circumstances, what will happen is that you have to arrange the proper theater list. Okay. And before theater, the patient must be seen by the anesthesia and operating surgeon in charge, keep in view of specific requirement, and arrange the theater list appropriately, which I have already told. Then the surgical safety checklist. So it is introduced by WHO in 2008, and we are also following the same thing in NMCTH, where the different it has a different headings. You can see the pre-list briefing, sign-in, antibiotic, monitoring, operation theater, environment, diathermy, tourniquets, timeouts, temperature control, hair removal. Everything will be entered in the surgical safety checklist. You can check it in the net whenever you talk about the surgical safety checklist by WHO. So you will see the various lists which has to be entered before the patient is intubated and the surgery is started. Okay. So scrubbing up, you people are very much fond of scrubbing up. Most of the time we have seen the students when they want to come to the theater and they want to scrub for the case, so that you will get chances while mostly during your internship, and that time you have to, there is a various process of washing hands and arms and putting on the gloves and gowns. So most of the time we use this povidone iodine scrub, hand scrub, and uh, initially with soap and water, and then followed by povidone iodine hand scrub. Okay, so various things can be used, like 2% chlorhexidine or alcohol, but we use povidone iodine and the soap. So these are the things. These are the details of the things. How it has to be done. Okay. See, now you can see some picture of how you are going to scrub. Okay. So this you need not jot down. Okay. So you just see how we are going. We usually do it, and how to put the gown. Okay. So these are various. There are different pictures, and then how to put it properly without touching the sterile area. Okay. So this is the picture showing the uh, how to put the gown. So now we'll go into specific preoperative problems, referrals, and management. So in that, some specific problems we'll talk about where the patient needs the referral. Okay, so preoperative management of the patient with systemic disease. So capacity, that is the baseline organ function capacity, should be assessed. Optimization, medication, lifestyle changes, specialist referral will improve organ capacity, and alternative like minimally impacting procedure, appropriate post-operative care will improve outcomes, and theater preparations, timing, teamwork, special instruments, and the equipment. So preoperative management of the patient with the various systemic disease, like now the cardiovascular disease, hypertension, ischemic heart disease, okay, arrhythmias, valvular heart disease, anemia, respiratory problems, gastrointestinal disease. So we'll deal in short a little bit of all the types. Okay. So with regard to cardiovascular disease, so most of the times when you see the patient in the outpatient department, you will see the patient with some history of ischemic heart disease, or the patient has some congenital or maybe the acquired heart disease, or the patient have arrhythmias, or the patient has a peripheral vascular disease. So it can be evaluated by various means. So most of the times, initially we do an EKG, that is ECG, and then the ECG will show the various changes, and then now we'll refer once the ECG is done. So it also depends on the age. Okay, if the patient is usually, previously the guideline was if the patient is, you have to do, in our situation is that you have to do a clinical examination of the patient. If the patient, most of the time, if the patient is more than the 40 or 45 years age, then the patient have some symptoms like dyspnea on climbing upstairs, and all these sort of patients, or the patient has to undergo a very major operation, like you want to do an Whipple's procedure or a gastrectomy or an hemicolectomy. So these sort of patients, you have to have an echocardiography done, and the ejection fraction of the left ventricle has to be mentioned whenever you are doing the echocardiography. And if the ejection fraction is less than 30%, then the outcome, the surgical outcome, may become worse. Okay, maybe poor. So what will happen is you have to evaluate the echocardiography and see the ejection fraction. Okay, and refer it to the cardiologist if required. Okay, even the ischemic changes in EKG, or so abnormal rhythm on EKG, you have to have a cardiologist consultation. So some patients with hypertension, ischemic heart disease, and stents. So the prior to surgery, the blood pressure should be controlled to around 160 by 90 millimeter of mercury. So it is just an arbitrary value, just for you to understand that it should not be more than the normal, upper limit of normal. And even if you see the hypertensive patients, then you have to consult the cardiologist, give the medication, cardiologist or physician, give the medication, and for 2 weeks minimum, so that the pressure comes under control, and then you plan for further intervention. Okay, but if the patient have an hypertension and some ECG ischemic changes, you are doubtful about it, then you may ask the patient to undergo an stress echo. So that has to be in a controlled situations where everything will be monitored. And if the patient is doing a stress echo and then you see some changes in ECG, you stop the patient. So everything has to be monitored, and then you have to take a calculated risk and explain it to the patient. Okay, and the patient with an stent, usually they will be having some the antiplatelet drugs, or and the ecosprin, which has been used to thinning of the blood. Okay, used for thinning of the blood. So these things has to be taken, the history has to be taken, and if they are taking any of this, then it has to be stopped. I'll talk about that later. So some dysarrhythmias can be there. So it will be seen in the ECG. The patient may be in atrial fibrillation. So patient might be taking some cardiac drugs. Okay, or maybe the patient has an pacemaker in situ. Okay, and so some symptomatic heart blocks can be there, or the second or third degree heart blocks. So all these things needs a cardiology consultation. Everybody is listening? Hello?
Yes, sir.
Yes, sir.
Okay, okay. So you are understanding, right?
Yes,
Hello?
sir.
Okay, okay, okay. So you are listening. Okay. So valvular heart disease. Okay. Some patients, you have heard about mitral stenosis or aortic stenosis. So these are the two conditions which are a little bit critical when you are operating the patient. Mainly the aortic stenosis patient and the severe mitral stenosis patient. You have to be very, very careful. Okay. So if the patient has a mitral valve prolapse and the ejection fraction is around 60-65%, then you may see, okay, it is all right. But if the patient has an aortic stenosis, then you have to be a little bit careful, because the ejection fraction will be can be detrimental when you are dealing with the patient with aortic stenosis. So remember, the severe mitral stenosis and aortic stenosis patients has to be evaluated very thoroughly. Okay, the rest of the valvular heart disease depending on the patient's symptoms, but be alarmed with these two things. Okay, and the patient with mechanical heart valves, usually they will be on warfarin. So you have to stop the warfarin 5 days prior to surgery, and so you have to have an heparin infused. Okay, so 12 hours before the surgery. Okay, and the INR has to be less than 1.5. Okay, so and post-operatively, if the patient is on warfarin, pre-operatively you have stopped it and you have put the pre-operative heparin, 12 hours before surgery you can give that. Okay, and then the post-operatively you have to continue heparin in the post-op, and then after a few days then you have to overlap heparin with warfarin for about 3 days, and then stop heparin and continue with warfarin. Okay, so now what one thing you have to do is, why you have to stop heparin, overlap with heparin and overlap with warfarin for 3 days, and then stop heparin completely and continue with warfarin. So everybody will read about it and find out why it is done like that. Okay, so those patients who are on warfarin due to maybe valvular heart disease, or maybe having history of deep venous thrombosis, where the warfarin has been put to the patients continuously. Okay, and anemia and blood transfusion. See the preoperative assessment. Sometimes the patient can have the patient having come. They may come with a bleeding PR, history of bleeding PR, where you find the carcinoma of the cecum, which has not been diagnosed. And when you investigate the patient, you will see the patient is anemic, severely anemic, maybe around 6 or 5 hemoglobin. So in those sort of cases, you have to lift up the hemoglobin give transfusion preoperatively, the pack cell transfusion, and give and you have to rise the hemoglobin for at least before surgery. We prefer yet the hemoglobin to be 9. Okay, so 9 because it is cut-off limit for the elderly, and the young people can tolerate a little bit of lower level of hemoglobin, but if you are going to undertake a major surgery, so we'll prefer it to be a 9. So okay, so you have to investigate about the so maybe it is due to the disease itself, the patient might have lost blood, or maybe there are some other comorbidities which has led to the chronic anemia. Okay, the patient having with chronic renal disease who comes for surgery of a gallstone, so in those sort of cases also you may encounter anemia. Okay, so we in our institute we prefer the hemoglobin for a major procedure 9 gram at least. But if you see in the textbook, as I have mentioned there, it will be around 8 gram for young people, and if it should be more, so at least 10 for the elderly population. Okay. So respiratory disease, current respiratory status should be compared with the normal state. So whenever you think of some chronic obstructive pulmonary disease or history of tuberculosis, the history of tuberculosis and the lungs has been, fibrosed, or there is history of some intervention to the chest because of trauma, and in those sort of patients, his or her pulmonary function can be less than the normal. So, and the thing is that these are the situations where you have to evaluate the pulmonary function status. So how you are going to do it? You are to ask for a pulmonary function test where you have to do a FEV1. So the FEV1, you have to see whether the FEV1 of the patient that is normal or not. Okay, so that will be mainly you will refer it to the pulmonologist, and he will do a pulmonary function test and tell you about the the different various status of the patient. Okay, so then the patient on COPD patients maybe, or asthmatic patients maybe on steroid. So you have to know the status of the steroid patient, how much dose he's taking or she is taking, because long-term use of steroid in a higher dose, like up to 10 or 20 milligram prednisolone, may affect your surgical outcome. So these situations usually arise in different situations, like whenever we talk the patient about an ulcerative colitis, and the patient comes with an the pancolitis, or it is refractory to the medical treatment, and he or she has to undergo emergency surgery, and the patient will be on a long-term steroid. Then in the intraoperatively you have to use hydrocortisone, and then the postoperative also you have to continue hydrocortisone. In those situations you may get some pulmonary complications and other complications like wound descent. The patient may go into sepsis. So you should know about the steroid use. Okay, and usually the patient on the respiratory any problems, you have to ask the patient to stop smoking, do exercise, and there is a something called as respirometer, which will be used for training the patients. So the respirometer, you'll see in the ward, it's very simple device where the patient can just do an inspiration and expiration exercise, and there will be small ball like balls will be there, and then that will be pulled up and down on inspiration and expiration. Okay, so that sort of respirometers are there available, which can give physiotherapy to the patient. So whenever you are planning a surgery in a patient, in those sort of patients, you ask them, if you are planning a major surgery 1 week or 2 weeks prior, you can ask for a respirometer and teach the patient how to do an incentive spirometry. Or you can and you have to ask the patient to stop smoking, and you can ask the patient to take some stimulation twice a day, and get ready for the surgery. So which will give you a better outcome in these compromised patients. So respiratory physicians, usually they will deal with the patients, but you also have to monitor whether the patient is doing or taking the treatment properly or not, okay? Because that will give rise to increased morbidity and mortality in if the patient doesn't follow the instruction properly. So smoking, as I've told, as asthma, COPD, and infections. Okay, if there are infections, smoking, asthma, and COPD, I've told you. But infections, if you see some chest infections, so they are treated with antibiotics and operations rescheduled after 4 to 6 weeks, because if the patient is having chest infection and he or she has to undergo an elective surgery, it is not possible, okay? Because see, this will give rise to post-operative complications. The patient may land up in ICU even if you do a simple procedure like a cholecystectomy, laparoscopic cholecystectomy, or an appendectomy. So in those sort of situations, what will happen is that the post-operatively the patient may have a flare of infection. And so whenever you see any chest infection in an elective patient, then electively posted patient, then in that case we have to first treat those infections, and then only you have to undertake the surgery. So gastrointestinal disease, there are various gastrointestinal disease, but just note this. See, I mentioned that there is not to take solid within 6 hours and fluid within 2 hours before you give an anesthesia. See, previously we used to ask the patient to fast overnight. Okay, so by 8 or 9 o'clock the patient will take food, so they will fast for 12 hours almost. Okay, so next day 9 o'clock only will take up the surgery. But nowadays the concept has changed a little bit. So if they have taken solid, then they have to fast for 6 hours minimum. And if they have taken clear fluids, then they can just be taken for surgery 2 hours before giving anesthesia. And then infants allowed to clear drink up to 2 hours, and mother's milk up to 3 hours, cow or formula milk up to 6 hours before anesthesia. So these are the important things whenever you come to practice. If you take children, okay, and then you ask them what he or she has taken. Usually, I'll not talk only of infants, but suppose some 7-8 years old child, you want to operate on some hernia or a hydrocele, and then you ask the mother what he or she has taken. Then they'll say that okay, he has taken a cow milk. Then it's better to wait for 6 hours before giving anesthesia. Okay, so that is one thing. And regurgitation risk, if you don't do all those, if you don't keep the patient nil parvoral, then in that case the patient can have pulmonary aspiration. So whenever the patient is have fed and then you do it immediate surgery, and in that case if you don't take precautions for blocking the airway from getting aspirated, in that situations what will happen is that you land up with a big trouble. So aspiration, pulmonary aspiration of the gastric content is most of the time life-threatening. Okay, so this history, or the patient is fasting or not, is very, very important. So in emergency situations, you manage with H2 receptor blocker, or you give a antiemetic also before the induction of anesthesia. And then liver disease. So you have to take care of the liver disease. If the patient is a cirrhotic patient, you classify the cirrhosis into child A, B, and C, which you may not understand now, but later when you come up with the 6th, 7th semester, you will know about it. So you classify into A, B, and C, and accordingly you do a liver function test, and you look for the various problems like ascites, do an ultrasound, know whether there is a fluid in the abdomen. Ascites is fluid in the abdomen. Then hypoalbuminemia with the protein, you do a blood test and know whether the albumin level is normal or not, and then the sodium and other electrolytes. Okay, and then you do an urea, creatinine, and then you do a performing time also, and bleeding time and clotting time. So liver function test will tell you whether the liver and the prothrombin time will tell you, and the albumin will tell you, and the ascites will tell you whether the patient is having any active liver disease, and which will be detected by an ultrasound and the fibro scan. So nowadays the fibro scan, which will usually know the nature of the fibrosis of the liver. Okay, so in those sort of situations you have to evaluate that. So genitourinary disease, okay. So a little bit about this. I'll just see that most of the time an elective case we will see the renal function test, that is urea, creatinine, and then the electrolytes like sodium and potassium, and then do a urine routine examination. So in that you will know whether there are pus cells, WBCs, urine is infected, bacteria is there or not. So all those sort of things we will check, and then we will plan. And then in specific situations like the various renal failure leading to acidosis, hypocalcemia, hyperkalemia, it has to be discussed with the nephrologist, like acute renal failure, chronic renal failure. Okay, so in those sort of situations the chronic renal failure patients should be consulted with the nephrologist, and an acute renal failure could be due to an emergency situations like abdominal bowel wall, abdominal hollow viscous perforation, or peritonitis, or sepsis due to peritonitis. In those sort of situations, you have to first resuscitate the patient and consult a nephrologist in the pre-op and the post-op. If nephrologist is not available, then you have to manage the urine output of the patients along with the renal parameters. So these sort of things in acute setting, but because that could be an emergency operation. But in chronic cases, you have a time, and then in those sort of situations, you can take your time and manage with the consult with the nephrologist. So urinary tract infections, if it is seen, elective cases should be postponed, and then you give antibiotics and recheck for the urine infection. If it is an emergency surgery, you give antibiotic to ensure there is a good urine output during and after surgery. But for elective surgery, is infection has to be treated, because sometimes what happens in orthopedic surgery like joint replacement, if there is a urinary tract infection, that can lead to a disaster situations where you do a joint replacement and then it gets infected. So that will be a very morbid situations, and a very difficult situation for both surgeon and the patient. So endocrine and metabolic disorders. So in that you have to see nutrition of the patients. So you know about the WHO classification of BMI for the Asian continent. Okay, so where there is the less than 18.5 is the nutritional impairment, and less than 15 is significant hospital mortality. So it is classified. You can see the classification in the net. Okay, so WHO classification for body mass index is different for the Western population and for the our population. So you can see that. Okay, so then obesity. So you should know about the body mass index, because that will fairly give you the nutritional status of the patient. And if the body mass index is very less, like less than 18.5, then you have to evaluate the nutritional status of the patient by seeing various other parameters. And obesity, yes. So obesity is also a very challenging situations where the patient can have, the deep venous thrombosis, or there are other complications, respiratory complications. Okay, so that has to be tackled. So most of the times, if we plan for an elective surgery and the patient is obese, and then we ask them to reduce some weight and come after a month or so. But if the patient is undergoing it's himself the obesity surgery, then the situation is different, where you ask the patient to do some exercise, pre-operatives, again the respiratory exercise, and take various precautions, and then you have to plan for a DVT prophylaxis during surgery. So all these things has to be taken care of. Diabetes. See, this is the most common problem where we encounter in the pre-operative patients, where the diabetes which can be insulin dependent or non-insulin dependent, which has to be monitored. So SbA1c level, as you know, that it will give you the status of the control of diabetes for the past 3 months. Okay, so SbA1c is a must if the sugar is not controlled properly, and you can manage the patient with insulin or the oral hypoglycemic drugs preoperatively and plan for surgery accordingly. Okay, so and then okay, so I'll skip this one. And coagulation disorders, the again the thromboprophylaxis for needed for obese patients, or history of trauma, or bedridden patients, or pregnancy or porphyrium. So all these things has to be taken care of. So and the patient who are on hormonal replacement therapy, they have to be usually after menopause, they take hormonal replacement therapy, so it has to be stopped 6 weeks prior to surgery. Okay, and okay, so I'll not go into detail. So you have to get a thromboprophylaxis. Neurological and psychiatric disorder, this has to be this has to be taken care of. So if the patient is having some stroke and the patient is on antiplatelet or anticoagulant, like it has to be withdrawn at least 7 days for aspirin and 10 days for clopidogrel. Okay, so that is also an antiplatelet drug. So at least 7 days of aspirin and 10 days of clopidogrel. So it has to be stopped. These medications will be taken by stroke patients. Okay, and then and lithium 24 hours prior to surgery. So some psychological disorder, we prescribe lithium, and in that case it has to be stopped 24 hours surgery. So we have to concern the psychiatrist and the anesthesiologist regarding the antipsychotic drugs, which has to be stopped or which has not to get stopped. So, but most of the times you will encounter the antiplatelet drugs, aspirin, clopidogrel, or a lithium. So these are the drugs which has to be stopped before surgery. The rest of the drugs we have to discuss with anesthesiologist. Okay, and musculoskeletal and other disorders, like there is an unstable cervical spine. In these sort of cases, when you do an intubation, the patient has to extend the neck. So if there is an unstable cervical spine, it may get displaced, and can cause compression of the spinal cord, so that can paralyze the patient. So whenever you talk about the cervical spine, you have to be very, very careful. Or the patient with ankylosing spondylitis, so there is ankylosis of the vertebral body, and there will be very little space between the two vertebral body. So whenever you talk, we are planning for a spinal or an epidural anesthesia, so in those sort of cases you may not get the space to give an spinal. So what will happen is you have to anticipate the problem, and then you have to plan it accordingly. Okay, so this I have already shown you the Malampati score. Okay, so remember this Malampati one. Okay, and preoperative assessment in emergency surgery. So this is also again a difficult topic. So in life-saving surgeries, most of the time you try to, whenever you see a patient with some trauma, bleeding, active bleeding, or maybe a hollow viscous perforation peritonitis, whenever the patient comes in a state of shock, or 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 maybe some emergency surgeries like appendicitis, or maybe cholecystitis. So in those sort of situations, you have to act accordingly. So if the patient is in a state of shock, you have to first resuscitate the patient and open a wide bore cannula, and then start resuscitating the patient, take samples for blood investigations, and then give oxygen to the patient, try to stop the bleeding if it is seen external bleeding. Okay, position the patient properly, and then you take the patient to the operation room. So now the post-operative problems. Okay, so once now you have seen some pre-operative status of the patient, and now the post-operative problems. Once you operate the patient, what will happen is intraoperative also is a little bit important, because there can be some intraoperative events. The patient might have gone into sudden hypotension during surgery, maybe due to bleeding, or maybe the patient which is on sepsis, you are operating, and during surgery he may crash. Okay, the blood pressure becomes very, very less. The patient and the anesthesia will start on inotropes, okay, noradrenaline or vasopressin they will start. Okay, so dopamine, dobutamine. Okay, so all these pressure supports. So patient might have been in this situation. So in that cases, you have to anticipate the post-operative problems. Okay, so post-operation, post-surgery. Suppose you have done a very simple surgery, and then first a few things you have to take care is the respiration of the patient and the pain of the patient, the fluid management, IV fluid management, the urine output of the patient, and if there is some intraoperative event, then you may discuss with the anesthetist and shift the patient to the intensive care unit and manage the patient in that. Okay, so what is needed? The immediate recovery and requires to detect early signs of complication. So whenever you see some patients, we have another major surgery. So you have to detect. Suppose the patient had major surgery and the patient bleeds on post-operative ward or maybe in ICU. So you have to anticipate those problems, and then you must have put some drains in the abdomen, and then that might show some bleeding from which is a very fresh, and then it keeps on coming and the patient is deteriorating. So all these things, the respiration of the patient, the pulse, the blood pressure, the temperature, the central venous pressure, if you have put a central line, the urine output, and the pain, most of the situation, the pain management. Okay, so these all has to be taken care of. So it will be done by the in the post-op ward by the nurses and the residents, and in the ICU by the critical care specialist and residents. Hello,
Yeah.
hello,
Orang masuk berkata di mata.
Suniya now. I am not able to hear. Can you see this? Can you listen to me?
Yes, sir.
Okay, okay. Shall I continue?
Yes, sir.
Okay,
New scientific information.
okay. Can you see this? There is a picture. Okay, so the picture where you can see the monitor. Okay, the monitor where you can see the heart rate of the patient and the saturation of the patient. Okay, somebody has unmuted this. Please keep on mute. Okay, the 74 is the heart rate. The SpO2 is saturation is 100%. You can see that the blood pressure is 120 by 74, and the respiratory rate is 15. Okay, so this is a usual monitor which you can see in the post-operative ward. Okay, so that 90 is the mean arterial pressure. Okay, so this is a very normal monitor which you can see in the post-operative ward. So you can see how the nurse is monitoring the vitals, and this is a, you can see right bottom, you can see the saturation probe which will tell you all these, and the blood pressure is shown by the blood pressure cuff. Okay, so all these parameters can be seen in the post-operative monitor. Okay, and then intake and output, you can see the how the IV fluids are hanged there. Okay, and so airway protection, can you see this is called airway? Okay, so airway, you can see in the left upper there is a mask, patient is on a mask, and oxygen is being given to the patient, and in the right upper you can see a patient in the post-operative ward with an oxygen supplementation, and in the right lower you can see the airway. You call it an airway. So what happens is some fatty patients where the tongue is very big, in the post-operative, you give an oxygen and then the tongue will fall back, and then the patient will start making some sounds. Okay, so that means that is obstruction of the airway. So what will happen is in those sort of patients the breathing won't be proper. So you put an airway to those patients, put in the mouth, and that airway will you know will make the patient able to breathe properly, and you can deliver the oxygen. Okay, so using this airway, you can see in the right bottom, these are the various airway tubes which is placed in the mouth into the oropharynx, and the patient can be patient can breathe easily with this airway. And IV fluids has to be given, and then this you can see a blood has been given in this case. So so if the patient was in a state of hypovolemic shock, or maybe intraoperative there was a blood loss, and you want to give the patient to maintain the blood volume. So in that case you have to you should be knowing about the blood group, and then you have to cross match. You should have arranged the blood pre-operatively, so you cross match, and then if it is matching, then you check it again and again, and then give to the patient. You can see there. Okay, so assessment of the surgical site for hemorrhage. So there are various type of hemorrhage, like primary, secondary, and the reactionary hemorrhage. Okay, reactionary hemorrhage usually occurs in the post-op ward. Okay, within 48 hours of surgery, because of slippage of ligature. Okay, so you have put some ligature, intra-abdominal surgery you have done, and then and what will happen is in the post-op, after the patient pressures becomes normal, then what will happen is those ligatures will slip in the post-op, and then the patient starts having bleeding. These sort of problems usually we see in the case of thyroid surgery, where the ligature has been put, and then after during extubation, when the patient is being normalized, at that time there will be a lot of rise in pressure, blood pressure. In that time we have not put the knot properly. In that case the knot will slip away, and the patient will start bleeding from that vessel which you have put the knot. Okay, so in those sort of situations you may have to re-explore that area and tie the or control the do an hemostasis. So you should always have a eye on the area which you have operated, or whether it is soaking or not, or if in the case of abdominal surgery you should look for the drain, and then you should look for the vitals also. So sometimes what happens is the drain is not draining the whatever is bleeding inside, and then the patient is sinking. So in those sort of cases the pulse will rise, the blood pressure will drop, and the urine output will drop. The patient will become tachypneic, pale looking. So all this sort of assessment has to be done. Okay, if it is an external bleeding, in those sort of situations you can put a pressure dressing and then try to control the bleeding. If it is not possible, you call your seniors, and then you take the patient to the theater if it is required. Okay, so main is the relieving pain. So most of the surgery is the pain relieving. So most of the time what will happen is that if you plan a major elective surgery, we give an epidural anesthesia. So if you can see in the left upper side, there is a epidural catheter placed in the epidural space, and through that you give a painkiller like morphine, or mix it with bupivacaine, that is a spinal anesthesia drug. So you mix those things and give through the epidural space in the post-op period, and then that will give the whole lower limb and the lower abdomen and the upper abdomen, that will relieve the pain. Okay, so in those sort of situations, that is known as epidural analgesia. And post-operatively, all patient doesn't require epidural analgesia. Suppose you have done a hernia surgery, groin hernia, or an hydrocele, or some surgeries which doesn't require an epidural, like a laparoscopic cholecystectomy. So in those sort of situations, you can just give an NSAIDs by injectable routes. Okay, and then supplements, maybe opioids if required. Controlling nausea and vomiting, there are various drugs available. You can give metoclopramide or ondansetron. Okay, post-operatively. And so when to be discharged from the post of ward or the resuscitation room. Okay, so RR means resuscitation room. So the most of the places, the post operative ward, they call it a resuscitation room, where the resuscitation facilities are there. So when the whole patient is fully conscious, respiration and oxygenation are satisfactory, patient is not in pain, the pulse, blood pressure is within normal, saturation is normal limit, oxygen, fluid and analgesia he or she is getting as prescribed, and no concern related to the surgical procedure. So usually the duration of the post-operative ward stay or the resuscitation room is about 6 hours, depending on the type of surgery. If it is a hernia surgery, maybe in a 1 or 2 hours you can shift the patient to the ward, depending on which anesthesia patient has taken. Or specific complications management system. Respiratory complications, the patient can have post-operative pneumonia, or the patient undergone a various big procedures like liver resection or a Whipple's procedure, and we have not done a thrombolysis, or the patient is prone for the venous thrombosis, or you have not put an stocking during surgery, stocking the lower limb stockings during surgery. In those sort of situations, the patient may get a deep venous thrombosis and pulmonary embolism. Most of the time, the femoral fracture patient, which has gone an intramedullary nailing, or pelvic surgery patients, may develop an pulmonary complications, and you can have morbidity and mortality. So, and you should also look for the aspiration pneumonia, or the patient is not maintaining oxygen saturation, or the patient is, if you do an arterial ABG, uh, arterial blood glands analysis, so you will know whether the patient is having normal oxygenation, or the patient is having hypercapnia, the carbon dioxide level will rise, okay, or the patient is having acidosis. So post-operative hypoxia, so absence of air movement, seesaw movement of the chest, supraesternal recession and cyanosis. So cause of hypoxia. So could be an upper airway obstruction due to residual effect of anesthesia, laryngeal edema due to tracheal intubation, hypoventilation, atelectasis or pneumonia, pulmonary edema of cardiac origin, pulmonary embolism with sudden chest pain. So these are various causes of hypoxia. The treatments should be treated urgently. You administer oxygen at the 15 liter per minute using a non-rebreathing mask and head tilt, chin lift, and jaw thrust. So this you will be taught in detail with the anesthesiology team. Okay, so suctioning of any blood or secretions, and then you may have to re-intubate the patient and ventilate the patient. If there is pneumonia, you look for the X-ray. There is a patch on the X-ray. You give an antibiotic, chest physiotherapy, and bronchodilators. If on pulmonary edema, sometimes what will happen in the post of the saturation will start dropping, and the patient can have frothy sputum, the frothy white sputum in the mouth, and you suspect pulmonary edema, so you give an diuretics like injection, furosemide, or you consult a cardiologist. Cardiovascular complications could be, the most of the time it is hypotension. So hypotension, and it is due to either due to surgical bleeding, sepsis, arrhythmias, myocardial infarction, cardiac failure, tension pneumothorax, or pulmonary embolism. Depending on the cause, you have to treat the patient. So the patient will have cold, clammy extremities, tachycardia, low urine output, and low CVT. I have told you this already. So depending on the cause, you have to treat the patient. So if it is myocardial ischemia, you will see the changes in the ECG, and then you have to start oxygen, then give a glycerol trinitrate, morphine, or aspirin, and beta blockers or calcium channel antibodies may be started, and cardiologist should be consulted. Arrhythmias because of hypotension and ischemia, so needs continuous monitoring. So you have to resuscitate, okay, correct the acid-base imbalance, electrolyte imbalance, hypoxia, and hypotension. Okay, so urinary complications. Okay, so acute renal failure, so you have to at least have urine output. See, Urine output should be at least 0.5 ml per kg, more than that. Okay, just remember, if it is 0.5 to 1 ml per kg per hour, every hour, then what will happen is it's a normal urine output. So that will come to around 30 ml per hour for a 60 kg portion. Okay, so you have to take an hourly urine output. Okay, and then if two or three successive, the urine output is less than 0.5 ml per kg for maybe 6 hours, then you have to check whether the catheter is blocked, or maybe the patient is having hypovolemia, the blood loss is there, or fluid is not adequate, or the patient can have metabolic acidosis or some electrolyte disturbances, or you are using a nephrotoxic drug. Urinary retention usually seen in hernia surgery or a pelvic surgery. So we routinely catheterize the patient if we are doing a major pelvic surgery, or if it is a difficult hernia surgery. But if simple groin hernia surgery, sometimes the patient can have urinary retention following spinal anesthesia. So it has to be, the patient has to be catheterized in the post-op period, and you have to remove the catheter later. But for 1 or 2 days, you may have to put the catheter in situ. Urinary infection, if the patient presents with pyrexia, the patient has fever, then you have to check the urinary infection, and then see what is the cause of fever. So whenever you see fever in the post-op period, 2 or 3, then you have to suspect many things. Okay, uh, so I'll come to that. So abdominal surgery, yes, the first post-operative day, the patient will have paralytic ileus, and then sometimes the patient can have infection of the wound, that is after 48 hours, and anastomotic leakage usually seen in 6th or 7th day. And orthopedic surgery, as the neurovascular status of the limb and external fixator site and compartment syndrome. Okay. The next surgery could be accumulation of blood, like as I told you in the thyroid surgery, and nerve palsy. Thoracic surgery, yes, you have to do a continuous ECG monitoring, see the chest drain. Okay, look for any evidence of pneumothorax or pleural effusion. Neurosurgery, raise ICP monitor. So the patient will present with vomiting, bradycardia, hypertension. So continuous monitoring. Okay, and then vascular surgery is a regular clinical assessment and Doppler ultrasound, Doppler assessment of the flow of the blood. Okay, and plastic surgery, when you have flaps or perfusion, needed to be monitored. Okay, with Doppler or clinical examination. Urology, catheters patency should be seen, and if there is any blockage, usually seen in the case of transurethral resection of prostate. So due to clot, there will be blockage, so you have to put the patient on continuous irrigation. Okay, so this we have already discussed. Okay, pain. So pain management has to be done with WHO pain ladder. So just note this and see it in the net. What is WHO? Initially you use NSAIDs or paracetamol, and if it is not relieved, then you use some local anesthesia or maybe the codeine. And then if it is still not relieved, if it is severe pain, then you give opioids. Nausea, vomiting, I have already told you. Bleeding, yes, primary, okay, or secondary or reactionary hemorrhage. Okay, secondary is usually seen after 7 to 10 days due to infection or sloughing out of the vessels. Sloughing out of the, you have put a ligature and the vessel gets infected. That part gets infected and it sloughs out and the patient starts bleeding. That is secondary hemorrhage. Reactionary, I told you, within 48 hours due to seepage of various ligatures or rise in pressure due to generalized oozing. So various causes. Okay. And deep venous thrombosis, as you can see, the calf pain, swelling, warmth, tenderness, and the patient can develop pulmonary embolism. Okay, so you have to use stockings if it is a prolonged surgery, and then use a heparin 12 hours before surgery and post-op also. So this I will not go into the DVT risk. And hypothermia and shivering, this is one of the most common complications following routine abdominal surgery, where you open the abdomen and then lot of heat, the body gets dissipated through the abdomen, open abdomen, so the patient can go into hypothermia. So you use the warm blankets during surgery, and then the room temperature has to be also managed, and in the post-op period. So that will be taken care by anesthesiologist and partly by surgeon. Fever, you just see this day 2 to 5 atelectasis of the lung, day 3 to 5 superficial and deep bone infection, day 5 chest infection, UTI and thrombophlebitis, more than day 5 wound infection, anastomotic leakage and abscess. So there are various causes of fever. So if you see fever in the first day or second day, it is usually due to atelectasis of the lung. So the lung, the chest physiotherapy is not good. So you ask the patient to do chest physiotherapy by using various techniques. Okay. So first day fever, second day fever, atelectasis of the lung. Okay. Most common cause, or be due to stress of surgery on the first day. So infection prophylaxis, we use antibiotics. I'll not go into that. Confusional state, okay. So that also I'll not go into detail. And then uh, okay. Drains. So you should always take care of the drains. So what type of fluid it is draining? It is serosanguinous blood or it's a bile. Okay. So bilious fluid. If you are doing some biliary surgery, it is bile or if it is blood or if it is serosanguinous. Wound care, after 48 hours, you have to see the wound, and then if it is a sign of infection, usually you have to manage it accordingly. We'll talk that whenever you come to our clinics. Okay. So now enhance. So it is called ERAS. Okay, enhance recovery after surgery. So just note this down. ERAS. Read about ERAS. So ERAS is a new concept which is coming up for the preoperative and intraoperative and postoperative management in various surgery. ERAS. Just jot it down. ERAS. Read about it. Okay. So this about the patient management, and we have to do a follow up of the patient regularly. Okay, I'll not go into that now in detail. Okay, so this is enough already. 1 hour is over. So everybody, just are you listening to me?
Yes, sir.
Hello. So see, a few things I've told you to note down. Okay. So one is that the ASA, the Malampati score, okay, and the BMI of the patient, how to assess the BMI, and then the post-operative things where you see about the deep venous risk factor for deep venous thrombosis, and then this ERAS concept. This is a new concept, enhanced recovery after surgery. So read about what is ERAS. You can see, you can find it in the net also, or maybe in your textbook. Okay. So and ECOG performance. So performance status of the patient, how to assess this. Okay. So all these things I have asked you to note it down. So preoperative and the post-operative management. So it is a vague topic. I cannot cover everything in this single class, but I think you have understood a little bit about how to manage the patient. Just tell me if